when we score these, and the maximum score is 7, if the cutoff value is 5, it says it's a better indicator for these women who are going for assisted reproduction. Now, ovaries play a very important role. The ovarian volume, which is more accurate, we just said how to calculate it. Sono ABC facilitates detailed follicle count. And also demonstration of a cumulus is much easier on a 3D as compared to a 2D. But what we see is the small anechoic cyst, which is within the follicle, which is the cumulus. And on the 3D, once we see that, we have to demonstrate it all 3 planes to call it that it's a cumulus ovaris. We can do the color flow and we can grade the vascularity from 25%, less than 25% to more than 75%. And vascularity of the mature follicle is graded on the percentage and the follicle circumference which is vascularized. So the more than 50%, it indicates a better oocyte retrieval rate, number of mature oocytes recovered, and fertilization rates. Then there are 2 areas where this helps us, is assisted reproduction. One of the areas is to predict the response of the ovarian stimulation to ovarian reserve. And to the second, endometrial receptivity, which I just talked about. Ovarian reserve is defined the size and quality of the remaining ovarian follicle pool at any given time and reflects the fertility potential of a woman. An accurate assessment of ovarian reserve is important prior to commencing ART, and because it helps the individual and also improves the treatment. It's ultrasound assessment of ovarian reserve involves ovarian volume. Less than 3 is a poor response, and more than 10 ml, it indicates that these women may get into hyperstimulation. Color flow, we look for to detect the total vascularization in the ovary, and obviously if it's an increased vascularity, the probable warning sign is that these people may go into hyperstimulation, and they have severe pain and they have so much ascites that one has to look after them. Antral follicle count is the best predictor of ovarian reserve and response. And these are nothing but resting follicles in both ovaries. They measure between 2 to 8 millimeters and should be assessed between 2nd and 4th post-menstrual day. And Sono ABC count is very good. It has improved the reproducibility and simplified the assessment of antral follicle count. It predicts the number of follicles which will develop with ovarian stimulation. It gives us the detail. We can have the sizes, we can have the number of follicles, and this blue tells us that these are not good follicles, and then they know that these are the follicles they don't have to go for. And we've already said that it's good for when the number of follicles are more than 10 to 15. We add the number of follicles to both ovaries and give a total number of count. And this has a very good positive correlation with IVF outcomes. And but I would also like to add, it does not change the difference. You can do a 2D count that's as similar as, it's going to give you similar results as what we do on 3D, except that on a 3D we have an advantage that we know we are not counting the same follicle again, and secondly, it's much faster. In polycystic ovaries, it helps us that it gives us the volume, number of follicles, and the size. And also when we do a 3D, it gives us much more number of follicles, which we on a 2D, as we can see on the 2D. And stromal vascularity assessment is easier, and it also indicates it's seen in polycystic ovaries that generally have on the second day increased vascularity. Coming to the next set of people where it helps is the abnormal uterine bleed. 30% of our outpatient visits to the gynecologist are with abnormal bleed, and these are polyps, adenomyosis, leiomyomas, malignancies, and endometrial disorders. The uterine leiomyomas are most common benign tumors of the smooth muscle and fibrous tissue, and they can occupy any part of the uterus. The size is variable. They may be single or multiple. It happens in about 20 to 30% of women with reproductive age group, and 40% of the women by the age of 40 have them. There is a genetic predisposition. Typically, they arise after menarche and regress after menopause. And clinically, they present with abnormal bleed, pain, pressure effects, and infertility and pregnancy loss. Now, these are described on the basis of when they're completely within the muscle there, they are intramural. When they are going into the endometrial cavity, they are submucosal. And when they're jutting out of the uterine cavity, they are subserosal. They could be hypoechoic, isoechoic, or they will show a complex internal texture. They may show stripy linear fan-shaped pattern. They may show cystic degeneration. And endovascular ultrasound is the modality of choice because it tells us how many there are. Smaller fibroids are better picked up. Submucous fibroids are better picked up. But transabdominal scan we have to do, especially when we are suspecting a large fibroid which is just outside the uterine cavity, and sometimes we may not be able to see it on the transvaginal scan. So the process of describing the location, the size and character of uterine fibroid is termed as fibroid mapping. This gives us information whether the fibroid is the cause of patient symptoms. Submucous fibroids are associated with secondary infertility. Intramural fibroid distort the uterine cavity and may impair embryo implantation. Large fibroids, they can increase the abdominal girth and cause abdominal and pelvic discomfort. Anterior leiomyomas usually have increased urinary problems as compared to the posterior myomas. They generally have lower backache and may be associated with constipation. And 3D actually plays us a big role with how to differentiate between a submucous and an intramural fibroid. So fibroid mapping is extremely important in patient management. As we can see here, this patient has a mass in the lower uterine segment, and here it shows a mass effect, but it's not distorting the cavity. So the surgical management depends on the type of appropriate surgery which we want to this thing, and this 3D helps us in deciding or gives us the gynecologist option to choose which kind of surgery they want. And also whether it's ultrasound guided hysteroscopic myomectomy or with radio frequency ablation. It's minimally invasive and the uterine sparing treatment guided by ultrasound. Uterine artery embolization is useful in shrinking the size of the fibroids and reducing the symptoms, and 3D is useful in monitoring these reduction in size. Because we have those images with us, we can always pull them out and compare them and put them
Thank you.
to look for if the size has reduced after embolization or after the GnRH analogs which have been given. So advantage of coronal plane is assessing the origin of the submucous fibroid, whether it's growing completely into the endometrial cavity or how much it's affecting. Radiant flow gives us improved vascularization. It gives us a pedicle stalk. It tells us difference between the submucous and the polyp. And when there's increased vascularity in a submucous fibroid and in this was a subserous fibroid, which is increased vascularity, one has to rule out malignancy in these. So when we're looking at the submucous fibroids, we're looking at the texture, whether they're hypoechoic. We look for the endometrial echogenicity. We look for the myometrium, whether the myoma texture, whether they're uniform, hypoechoic, non-uniform, echogenic. What is the response on the endometrium, which is a trilaminar, is it distorted or is it echogenic? And how far is it going into the endometrial cavity? And they are classified according to the proportion which is projecting into the uterine cavity. And currently, there are two classification systems which we use. One is FIGO system, and I personally prefer this one over the Lasmer's because Lasmer's is, it depends on the size, location, extension, in relation to the uterine wall, and penetration into the myometrium and the lateral involvement. It's a step. It's actually what it does is it's a scoring system. The higher the scores, the more difficult the hysteroscopic procedure is. So this helps for the surgeon. It's a very good classification. But I personally prefer the FIGO system, and which is this here. And it's not that 2D is not telling us what it is. These are all the fibroids which we can see on a 2D, and we can pick up on a 2D endovascular ultrasound. And but what 3D tells us is that how much is it growing into the endometrial cavity. These are all different coronal images of submucous fibroids. Now, when we are using FIGO classification, we can say that these are completely growing into the endometrial cavity, which is 0. More than 50% involvement, they are intracavitary. More than 50% of them are going into the endometrial cavity, or less than 50% in the intracavity. So, bulk of the tumor is in the myometrium, but less than 50% is going into the endometrial cavity, and that actually helps in a decision factor for what type of surgery we need. When they're intramural, they're completely into the intramural, they have no mass effect, they have nothing to do with the endometrium, they're just lying there, sitting there. And then the type 3 is the one which is in contact with the endometrial cavity. Subserous fibroids are those which are bulging out. These are type 5. And here what we would like to do is we measure the myometrial thickness which is around the fibroid to know which kind of surgery is needed. And when they are most of the tumor mass, which is if it's in the intramural, it is involving more of the muscle, that's more than 50% are classified as type 5. And type 6 are the ones where the major portion of the bulk of the mass is outside the uterine cavity. Transmural are characterizable relationship to both endometrium and the serosa. So here's one such fibroid. It has a mass effect on the endometrial cavity and has a mass effect on the serosa as well. They may, when there's a broad ligament, they have cystic degeneration. We can also look for the pedicle, which is type 7, according to the FIGO classification. Type 8, which has no relation to the myometrium, this could be cervical fibroids. And then there is the parasitic lesions, which have no direct attachment to the uterus. FIGO classification is very easy to use in clinical practice. Like I said, we can do it on 2D also. But the problem is it does not account for the size, the number, and different wall locations. So when we are trying to use this classification, if we describe that where exactly is it in the fundus, body, upper, middle, lower, cervix, or right, left, anterior, posterior, I think we have a pretty good description of saying where, what is actually we can use the FIGO classification. And here we have one such patient. This was the same patient. Here we have 2 fibroids, so we label both of them. So this is submucous, we call it type 1 because